Hi, I'm Kenneth Adams, a cardiologist at Pentucket Medical Associates. I'm very happy to be hosting today's segment of Matters of the Heart. This is sponsored by Haverhill Community TV and Pentucket Medical Cardiology. I'm happy to have with me today my associate Seth Bilazarian, who will be speaking with us about aspirin.
Great. Well, I'd like to talk about aspirin because it's an area that's pretty exciting but also often misunderstood by our patients in the community, and I thought it would be a good opportunity for you and I to talk a little bit about it as a medicine and how it stands. It's pretty interesting that it's been around for a long time. Its history dates back several millennia. The Egyptians supposedly used it, have a graphic about the history of it, and it was used by American Indians. They discovered that it was a derivative of the willow bark. But it wasn't really formulated as a drug until the 1800s by Bayer Chemical in Germany in the 1800s. So it's been around now for more than 100 years as a drug. And it's one of those things that has a variety of things that people know about, of course. People think about it as an aspirin for headache and whatnot. But its biggest use in the United States these days is really to either treat or prevent vascular problems, cardiac issues that you and I take care of every day. So It's a pretty exciting area. So what does aspirin do? I guess that we would start with to talk a little bit about that as an issue. And I think it's a really area of ongoing research, but it's also, I think, fairly well understood that aspirin's main effect is as a blood thinner, I guess we would say generically. And as a blood thinner, aspirin works by blocking the aggregation of platelets, fancy doctor term, but really what it means is these platelets that help us clot when we're bleeding, these platelets aggregate or stick together, and aspirin blocks that from happening. Now, it doesn't wipe it out completely, but certainly inhibits it substantially. So by blocking that aggregation of these platelets, it can prevent a clot from forming, and that's really what we think happens when someone has a heart attack or a stroke. So platelet aggregation is the thing that we're treating. There's really two parts of this whole problem, and on the graphic you can see the terminology here that doctors use quite a bit. It's called atherothrombosis. It sounds like a very difficult term, but briefly, the athero word refers to the plaque that causes the problem from cholesterol buildup in the arteries, and the thrombosis is the clot that forms that causes the final part of the problem, a heart attack or a stroke. So aspirin doesn't do anything for the plaque, but it does help reduce the chance of this clot forming that can cause either a heart attack if the blockage is happening in the heart arteries, a stroke if it's an artery going to the brain, or gangrene if it's an artery that's going to the foot, for instance. So that's a pretty exciting thing that's what aspirin does, and we're going to talk a little bit about that.
That's very interesting because aspirin is used by so many people. You mentioned how it can be used at the time to try to prevent a heart attack. But what about people who are taking aspirin on a regular basis who have really never had any heart attack problems in the past?
Well, if you're talking about aspirin use as a preventative, we certainly do recommend that as a primary preventive strategy, and we'll talk a little bit more about that. Aspirin seems to be less used these days by most people for the purposes of the headache or the backache or those kinds of things. And that's probably because we now recognize that if you take a lot of it, you're at risk for bleeding. It can upset your stomach. So most people use other medicines, of course, commonly Tylenol or ibuprofen, those types of medicines for those other kinds of problems. But more commonly, we are using aspirin primarily for prevention. The major studies that have come out here, and we'll just go to the next graphic and show the primary prevention, primary prevention means that we're preventing a problem before it happens. So that's what primary means. And the current recommendations is that every man in the United States should be on a baby aspirin a day, 81 milligrams, if they're over 50. And every woman should be on it if they're over 65. So that's really the current recommendations for primary prevention of aspirin. If we go to the next graphic, I'll show a graph from the data that came about from this. This was called the Physicians' Health Study, and it was done with male physicians in the United States, done many years ago. And what you can see in these graphic bars is that if you take aspirin in the front, the green bars, your risk of having a heart attack is much lower than if you didn't take aspirin in the back. But if you have a risk predictor blood test called the C-reactive protein, which we do commonly, the higher your risk, evidenced by the higher C-reactive protein, the greater your risk was if you didn't take aspirin, and that was reduced by taking aspirin. The one finding of this study that I think was very interesting was that if you were in the lowest level of risk, so if you were a man, even if you're over 50 and didn't have much risk, so you had a low level of that marker C-reactive protein, you didn't really need aspirin. It's sort of a common sense thing that I think we would all recognize, that if you're at low risk, you probably don't need as much prevention. If you're at high risk, you need more prevention. In between, we can have some difficulties. But that's the primary prevention strategy.
Sure. Now you mentioned a lot of people should be taking aspirin as primary prevention. Are there some people who should not be taking it? Who might want to avoid taking aspirin?
Well, if someone has, of course, an intolerance, a real allergy to aspirin, of course, that would be a reason. That's relatively rare. That seems to happen quite infrequently that someone has a true allergic reaction, whether it's dangerous, they have hives or some kind of breathing difficulty with aspirin. That's very uncommon, but can happen. The other group of patients that can be at risk are certainly people who have had a long history of ulcers in their stomach, bleeding in their stomach. Those people would be somebody who would be very cautious about using aspirin as a primary prevention strategy.
Now, there's a couple of different preparations of aspirin. So when you go to the pharmacy, you'll see the store brand, you'll see name brand, you'll see generic, enteric-coated aspirin or plain aspirin. What do you usually recommend to your patients?
I'd love to hear your view. Let me tell you what I recommend to most patients. But one area that I would want to caution, and I'd love to hear your input on this as well, is that it can be very confusing. So I know sometimes I tell patients to take aspirin, and sometimes I'm worried that they might think it's okay to take Tylenol or ibuprofen or Advil or Nuprin, one of these other medicines that can be confusing, because I've seen when I go in the drugstore, it may say non-aspirin pain reliever, and you see the word aspirin and you think you can take it. That's not doing the good things that we're trying to do to prevent heart attacks and strokes. So I guess I would say that first. It's got to be aspirin no matter what. I think we'd agree there.
I agree totally.
So then what preparation? I don't believe that people have to take a certain brand of aspirin. There was a time many years ago where we thought maybe that was necessary, but I think well, certainly I recommend that any generic aspirin is okay. If someone really has a problem with stomach upset with aspirin, we do recommend a coated type aspirin, because that seems to reduce upset stomach kind of issues. So an enteric-coated aspirin is a brand name called Ecotrin. I'm not recommending that per se, but that's one as an example. And we do recommend, the baby aspirin dose of 81 milligrams. How about you? What do you do?
Yeah, I have a very similar policy to yours. And years ago, I was always recommending the 325 milligram strength of aspirin, the full strength aspirin. And now for most patients, I think 81 milligrams is enough. A lot of studies have shown that's more than sufficient. And I tend to recommend the coated aspirin, because these are people who are going to be taking aspirin every day. And eventually some of them might develop some stomach upset, and it's probably less likely with the coated aspirin.
Okay.
As you probably mentioned at some point, if you're in the midst of a heart attack, you don't want to use coated aspirin, because you want that aspirin to get into your system immediately. Right. So when if you're unlucky enough to have chest pain, you have to call an ambulance, and they give you aspirin, they're going to make you chew it, and that's to get it into your system right away.
Right.
But if you're someone who's just taking it for prevention and you're taking it on a regular basis, the coated one is good.
Right. I agree.
So I think you and I are on the same page on the aspirin.
Great. So primary prevention then was what we just talked about, which means you didn't have a heart attack, you're a 51-year-old man. Certainly if you have risk factors like the main ones we always talk about, high blood pressure, diabetes, cholesterol, smoking, or family history, those 5 risk factors. If you have one or more of those, certainly we'd really want you to be on aspirin for primary prevention. That means you didn't ever have a problem yet. We're going to try to prevent you from having one. That's primary prevention. So let's go to the next graphic. Is secondary prevention means you already had a problem. We want to prevent it from happening again. So secondary prevention means you already had some kind of a definite vascular problem, whether that's a heart attack, a stroke, you had bypass surgery, you had an angioplasty, a balloon or stent type procedure, you had bypass of your leg arteries. One of these kind of vascular things happened. So we're no longer thinking you might have a problem. You have a problem, and we're trying to control it, prevent it from causing more injury to you. That's secondary prevention. In all of those patients, we recommend aspirin.
Now, a lot of patients come into the office and they say, I went to the pharmacy and I went to get my aspirin, and I also have a prescription for Plavix, another blood thinner.
Right.
And the pharmacist said I shouldn't really be on those two together, or maybe it's someone on Coumadin, another type of blood thinner that we use for other issues. Sure. And the pharmacist says, well, are you sure you're supposed to be taking your aspirin along with your Coumadin? Maybe you could give us some thoughts about that.
Yeah, I was hoping you could handle that, because that's a tough question. But I'll just say briefly that Coumadin and aspirin together is sometimes something we do recommend. But sort of a common sense, I think anybody would know that the more blood thinners you use, there's a greater chance of the blood thinner problem, which is bleeding. But there are certain circumstances where we definitely want you on Plavix and aspirin. For instance, after a stent procedure, they're highly recommended, mandatory, I would say. And there are certain circumstances where we use Coumadin and a baby aspirin. But we certainly would acknowledge that there is a higher risk of bleeding, but there's also higher benefit as well. And we're sort of always doing that balancing act. We think some doctors talk about the scale. On the one hand, risk of clot and heart attack, stroke, and risk of bleeding. So how do we balance out those risks? And it really has to be individualized. And that's why we ask patients to come and visit with us once or twice a year to review things, to make sure we're on track and make sure that these recommendations are ongoing.
Yeah, I agree. You know, I know an area of interest of yours is aspirin resistance. We haven't really talked about that yet, but you know, we say that everyone should be taking 81 milligrams of aspirin.
Sure.
But there's some people who have a different response to that dose of aspirin. Can you give us your thoughts about that?
Sure. The whole aspirin resistance area, we have a graphic about aspirin resistance. If we could put that up, that would be great. But it's really one of those things that's an evolving area of research that people are very excited about. But it's sort of, again, one of those things that after the fact, like many things in medicine, you say, well, that makes sense. And what's come out of this is some people don't respond to aspirin. Why would we even think that that should be? But that's the way we've practiced in the past. So aspirin resistance is now recognized as a problem in the last several years. It occurs in about 25 to 30% of people, it's thought, which means that they take the aspirin just like they're supposed to, but they don't get the blood thinner effect. And the benefit of aspirin, therefore, can't be demonstrated in a certain blood test that we now have available. I think we're one of the few areas in the Merrimack Valley that's actually doing this test in our office to actually measure aspirin resistance. And that's a readily available test. It's reimbursed by insurances. And we can now tell a person, yes, you are getting the effect, or no, you're not getting effect. The question is, what do you do about it? And that area has not been fully sorted out. But what my approach has been is if someone's been on the 81 milligrams of a coated aspirin, we do a couple simple things. One is ask the patient, have you really been taking it faithfully? And many times I found that a patient does say, you know, I haven't been taking it as much, and that's an easy thing to fix, assuming the patient wants to work with us on that. But the other thing that's easy to do, of course, is to increase those patients to a higher dose because, as you said, I agree with you completely that a 325 milligrams, the usual adult dose, is probably too much for everybody, but it may be needed in some people. So by individualizing the dose rather than giving everybody the same dose, we can treat the right patients with a higher dose who need it and keep the other patients on a lower dose that don't need it.
Yeah, very interesting. Do you usually increase the dose if you find that somebody's aspirin? Let's suppose they've been taking their aspirin regularly, and the aspirin resistance assay shows that they're somewhat resistant to it. Will you increase the dose and check the assay again? What do you do usually?
That is generally what I do. So if someone's been on 81 milligrams of aspirin, I did their resistance assay and it says that they are not getting the thinning effect that I expect, I would call the patient and discuss it with them. And it really is remarkable how often they say they haven't been faithful to it. But if they have been faithful to it, my usual approach is just to go right up to the adult strength. We could go to some intermediate level, take 281s, but I've been generally going right to the 325, which is the usual adult strength, and then reassessing a month or so later to see where the patient stands. Part of it, of course, is individualized. If the patient's on those other blood thinners that we talked about, I might make a different recommendation. If the patient's early after a heart attack, I might make a different recommendation. So it's hard to make general recommendations, but of course, we're doing the test to see if we're getting the effect. If we're not getting the effect, I would normally make some adjustment.
Now, I know you place stents in coronary arteries, and what's your recommendation for patients in terms of aspirin dosage after you first put in a stent? Because that's a critical time to be able to keep the blood thin so you don't develop a blockage within the stent. Yeah,
it's a great question. So stents are a really fantastic treatment that we now have available, helping patients avoid bypass surgery. But one of their disadvantages is that it's actually critical that the patients stay on Plavix and aspirin for a year. The general recommendation is that patients be on an adult 325 for the first month, but after that we think we can lower it to 81. But that has been our recommendation. We feel like that's probably the most sensible approach. But I'll put the plug in for something that I know you think as well, is that we always recommend patients who are on aspirin and Plavix after a stent to not stop that medicine without talking to the cardiologist. If it's one of us, I know we welcome those phone calls. Someone's going to see the orthopedic doctor about some surgery. They say, the doctor told me to stop it. What should I do? We want to be involved in that decision-making because it would be terrible to have a successful knee operation but have a heart attack in the meantime. So that's what we're really trying to avoid.
Absolutely. In fact, I just had one of these calls today about a patient who was going to the dentist and was on aspirin and Plavix. And fortunately, was just going for some routine hygiene-type work, and they really didn't have to stop their blood thinners. But if someone had just had a stent, let's say, within the past month, and they didn't really have to have anything done to their teeth, how long would you ask them to wait?
Well, the recommendation currently for aspirin Plavix is to have a full year of treatment before it stopped. So we say no matter what the procedure, whether it's dental, orthopedic, urologic, whatever the issue, if it's elective and can wait a year, we would prefer to see that. But a lot of this is a moving target because we're seeing the surgeons become more comfortable doing the procedures on aspirin Plavix. We have a discussion with the patient. Yes, you might have a little bit more bleeding with this procedure,
right,
but the safety of your heart warrants us taking that little bit greater risk. So it's a little bit of a balancing act. I think that all specialists, I'll criticize our profession, have the greatest interest in their own specialty. You and I were worried about hearts, and
sure,
of course the orthopedic doctor's worried about the knee, and we have to think about the whole patient, and it requires some discussion sometime in that regard.
Oh, I agree. And it's always, as you brought up before, it's always that balancing act. Like, what's the risk of bleeding versus the risk of a blockage in the stent?
Sure.
Or the risk of a heart attack versus bleeding.
Right, I agree.
Oh, that's very interesting.
So the last things I guess we would talk about is talk about some treatment, and you've already touched on this a little bit. So we have a graphic about some areas that are treatment, but the one that I think has gotten the most attention is the treatment of a heart attack. So if someone is in the throes of a heart attack, and those characteristic symptoms are pressure or heaviness in the chest with sweatiness or breathing difficulties, someone's having those symptoms, alerting the emergency medical response system. Calling 911 is the first and foremost, but we would recommend that those patients also take an aspirin immediately. If you don't, as you said already, usually the ambulance folks are asking them to take it. We ask people to chew it to get it rapidly into the bloodstream because we think that if you chew it, it breaks down and goes faster into the bloodstream. But that is clearly a recommendation if you have a heart attack to take an aspirin and to call emergency medical response services. But in the other areas we've already mentioned, a stroke and also a stent are also treatment where aspirin is critical. I would say so much to say that unlike the issue we were just describing where some surgical procedures don't want to be done with aspirin, the opposite happens when we work in the heart. If someone came and thought that they were supposed to stop their aspirin before coming in, I was going to do an angioplasty, for instance, if you sent me a patient, asked me to do their angioplasty, and they came and they said, oh, I stopped my aspirin a week ago, and I met them on the day of the procedure at the hospital, I would actually say to the patient, I'm sorry, we have to cancel your procedure because the data is that so much benefit comes from taking aspirin the day of your stent that we think it's unsafe to do it the day of the procedure. So that's a little of the treatment. We talked about primary prevention. We talked about secondary prevention. We're actually talking now about treatment of a real problem with aspirin. So that's a few areas of ongoing discussion in that regard.
You know, of course, aspirin is great treatment in the midst of a heart attack. What are some of the other things in your practice that you might use aspirin for? I know you mentioned for people who may have had a stroke in the past. What about for patients who have what we call vascular disease? So they have narrowing in the arteries that feed the legs, and they get pain in their calves if they walk a little bit too far. Has aspirin been helpful for those patients?
Yes, and there are many guidelines. The medical societies don't always cooperate. Like any profession, sometimes the one specialty doesn't cooperate, but in many areas, I'd have to say in vascular medicine, there's really been great cooperation. So as the area you said, leg artery blockage called peripheral arterial disease, there's been really great cooperation between the different specialties. Vascular surgeons, cardiologists, internal medicine have all really come together to agree that aspirin is really a critical treatment for patients to prevent long-term issues. And the idea being, to use the example that you've provided, if someone has vascular blockage in the legs, we strongly suspect that they may have it in the heart and elsewhere, even if it hasn't been demonstrated. So for that reason, we really think that aspirin is a strong recommendation.
Now, what if you have a patient who's had a heart attack, so this is secondary prevention, and they've tried aspirin a couple of times, and every time they try it, they get really sick to their stomach, nausea, feeling like they're gonna vomit, and they just can't take it. What would you have them take instead? Yeah,
I don't have an answer to that question. I mean, I would want to have an honest conversation with the patient, doctor to patient, to say, is it really a problem? Do you really think it's the cause? And of course, there are some solutions. Sometimes we can use medicines to help reduce the stomach upset. There are over-the-counter medicines. There's a medicine called Prilosec, which is excellent. There's an over-the-counter medicine called Zantac, which are strong acid relievers we could sometimes use to get the patient to tolerate the aspirin and reduce the likelihood of the stomach upset. But if you're asking me, despite all of these efforts, they still are resistant and they can't take the medicine because it's really uncomfortable, and that's truly the case, we have to say to them, well, you cannot take the aspirin, but you have to accept you will be at higher risk for another heart attack or a stroke. And if that's the case, we have some other options. The only other option would be an alternative medicine like Plavix. Now, I know that that's what you were thinking, and I know you also know and I just want to say for our audience that there's not a lot of information about using Plavix alone. Almost all the studies showing that Plavix is a wonderful blood thinning medicine have been done adding it on top of aspirin. So I don't know if Plavix is good alone. I only know if it's good on top of aspirin. So that's really the issue that we face. But we probably would do something like that. What are your thoughts?
Yeah, there's only one study that I know of, and it was from a number of years ago, where aspirin was compared to Plavix in patients with heart disease. And the Plavix actually came out a little bit better in that study. I know you're familiar with that one. So I think that Plavix is a reasonable substitute for patients who can't take aspirin. You've tried it a number of times and they just can't do it. The problem, though, is the expense. So Plavix is much more costly. Aspirin's very inexpensive.
Right. So we think aspirin probably costs under $1 or $2 a month, based on going to one of these large discount retailers. And Plavix is over $100 a month, so it's a dramatic cost difference. I agree with you completely.
Right.
Yes, so I agree with that. So I would say that I think that we've covered a lot of ground today. I'm not sure if there are other issues that you think patients in the audience or other people interested in this topic might have interest in.
I think you've covered it really well. I think we've talked about primary prevention, secondary prevention, some of the history of aspirin, and we've talked about aspirin resistance, which is a relatively new concept. So I really thank you for sharing your insights with us today.
Let me just mention that there's a couple things I do think that are happening in the future. I just have a graphic about the future of this area. There's a couple areas that are exciting. One of them is in the news this week. And I'll just talk about it. In the future, we may be tailoring therapy to people. We already talked a little bit about that. So instead of just giving everybody 81, we find the right dose. So tailoring therapy, I think, is part of the future. I'm guessing about these things, but this is what I would predict. I think there may be some future of combination pills. And what's in the news this week is that the World Society of Cardiology is meeting this week in Buenos Aires in Argentina, and there's a lot of news about this poly pill. And there are studies going on around the world about a poly pill. And the idea here is that many people with vascular disease need a bunch of different medicines. They need a cholesterol medicine like a statin. They need another blood pressure medicine called an ACE inhibitor. Many of them need aspirin, and many of them need a beta blocker. And wouldn't it be wonderful if we could give these medicines in one pill, so 4 medicines in one pill? So the poly pill is a potential future area of interest. And the idea that was discussed this week in the news at the World Society of Cardiology that I just mentioned is the goal of these manufacturers are to get this down to $2 or $3 a month for this poly pill. And wouldn't that be a wonderful thing if we could prevent a lot of vascular issues? The projection is we could prevent 80% of vascular disease with this kind of poly pill approach for $2 or $3 a month. It would be really fantastic.
Yeah, that would be great, because one of the problems we always hear from our patients is not only how difficult it is to take all these medications, but the cost is too much for most of us. And it would be great to have one pill, much better compliance. Patients would take it more readily. And if the costs were much less, it would be much easier to treat patients.
I agree. So let me just go to the final graphic, our key points that I think that we've talked about today, and I'll just summarize. So aspirin is real medicine. I think some people say because it's over the counter, because it's inexpensive, that they don't have to take it. But it's one of those critical medicines after a heart attack or a stent or a bypass. You've got to take it. It's real medicine. If you have coronary problems or have had a heart attack or a stent, you need to take this medicine, and don't stop it without calling your cardiologist.
Absolutely.
If it's you or I know we welcome those calls, and if your cardiologist doesn't welcome those calls, I hope that you'll encourage them to accept them. Aspirin effect or resistance is a new problem that we are acknowledging. It needs to be measured. And if we show that graphic again, I don't remember the last thing. Oh, side effects can occur. Stomach problems you've brought up as well can be managed. Bleeding is a real potential problem. We don't deny that these are real problems. We acknowledge them, but we really believe that the risk-benefit favors the use of these medicines in these subsets of patients.
Well, thank you very much, Seth. I've been speaking with Seth Bilazarian, a cardiologist at Pentucket Medical Associates, about aspirin. I think he's given us a lot of great information about that. Thank you very much.
Thanks for having me.
You're welcome.
add risk calculations for patients. So I think it's something that is an exciting area, and we're sharing this with patients in a new area of evolution. We don't have all the answers, but this is the first step on a journey that I think is going to be evolving in the coming years.
Great. I think that wraps up the topic of CRP. I'm not sure there's a whole lot more to cover. We started to talk at the end there about Crestor. That's a statin, a type of cholesterol medicine. So it seems with every passing day or news story, there are more indications for someone to be on a statin. More and more people who we've often thought of as low risk. So should everybody be on a statin? Should we just put it in the water, as many people say? And what is the cost implication of that? Is that a deterrent at all?
It's a great question. You're asking important public health questions. I would say we probably won't put it in the water, although fluoride was pretty successful. I would say that you could make a case for putting it in water, and there's actually been discussions at our heart meetings, just to try to address that issue. But I would say in the long run, the cost issues are in decline, because these cholesterol medicines are becoming generically available. We already have a couple of them that are available for only $4 a month. I don't want to be insensitive, but for many patients, $4 a month is a manageable cost even without insurance. The statins are becoming more available generically, so the cost for patients on insurance are $10 a month as a copay. So the cost is in decline, and there is a cost benefit of having less angioplasties and less bypass surgery, which are very costly. Okay. So I can't answer on a public health basis, but on an individual basis, I think patients who are an established risk criteria, the benefits clearly outweigh the risks, and I would heartily endorse these medications.
Great. Well, thank you, Dr. Bilzerian. I want to thank you for reviewing this important topic, and it was, I think, useful for me, too, to go through this. And on behalf of Haverhill Community TV and Pentucket Medical Cardiology, I'd like to thank you for joining us for this episode of Matters of the Heart. Thank you.